Hello, listeners. My name is Sarah.
And I'm Fahim.
And welcome to this podcast about language disorders in refugee children.
Before we dive in, just a little bit about ourselves. We are two SLP students at the University of Western Ontario, located on the traditional lands of the Anishinaabeg, Haudenosaunee, Lenapehoak, and Chinongton nations. Our topic today is language disorders in refugee children. This topic is very near and dear to our hearts as both of us come from families that were displaced by conflict. This podcast is primarily a resource for SLPs, but we're hoping that a lot of the content will be useful for occupational therapists, social workers, and any other healthcare professionals who might see a child from this population. So, Sarah, why did you feel that this topic was important?
This topic is especially relevant for Canadian SLPs given the large number of families who resettle here each year. In 2017 alone, over 25,000 children under 15 held official refugee status in Canada.
And I'll just add to that a lot of families come here as de facto refugees, but they have immigrant status here, despite the fact that they fled from conflict zones. And I mean, with global instability rising, this trend is unfortunately unlikely to slow down.
Yeah, and in this context, several epidemiological factors become especially important, broadly falling into biomedical, psychosocial categories as well. So, Fahim, do you want to go ahead and just describe some of these biomedical factors?
Yeah, thanks for setting that up, Sarah. Before I dive in, I should give a content warning. We are going to discuss some pretty triggering subject matter, and there's no way around it. But in case you're not in the headspace to hear about warfare, displacement, depression, genocide, then this might not be the right moment for you to listen to this podcast. In any case, let's start to flesh out an impairment profile that you might observe in these children. One of the major biomedical factors which can negatively impact language development is hearing loss. And whether it's a conductive hearing loss, sensorineural, a central loss, a mixed loss, every level of hearing impairment can arise due to armed conflict. The most obvious etiology here is gunfire or drone warfare. It's not just that hearing loss is more prevalent in war zones, the hearing loss itself presents differently. This is because children in war zones are far less likely to access hearing aids. This is usually due to poverty, but also because of disrupted supply lines. In a number of war zones, there is an explicit element of blockade. For example, the recent Saudi blockade of Yemen and the current Israeli blockade of Gaza. In these circumstances, it's impossible to get hearing aids in.
Yeah, and not just hearing aids, but also AAC devices or really anything necessary to support language-disabled kids.
Yeah, exactly. And this lack of early intervention is a theme that we're going to return to again and again. It is a major differentiator in terms of the clinical presentation and prognosis compared to what we as Canadian SLPs are used to. There are several triggers which can cause these children to develop auditory processing disorders as well. And as we know, the impact that auditory processing disorders has is profound, whether it's on phonological awareness, literacy, or language development more broadly. The second etiology I want to discuss is neurotoxic exposure.
Okay, but as SLPs, why would this be important for us to know?
All right, well, great question. I think it's important because we may be the first healthcare professional to flag these issues in terms of how they're affecting cognition. This gives us the task of looping in the schools and the doctors as needed. So just to make this more concrete, war has a nasty tendency to disperse toxins into the environment, which can affect the developing brain. To give just one example, we have heavy metals like lead, which are found in artillery as well as infrastructure which may have been bombed. We don't really see much lead poisoning in Canadian children anymore, of course, with the exception of Indigenous children who are impacted by environmental racism. But I would bet that most new SLPs here have no frame of reference for how lead poisoning can affect language development.
No, we don't.
No, but it's been shown to be linked with poor phonological skills, poor vocabulary development, poor grammatical reasoning, ADHD, sensory integration deficits, intellectual deficits, slow processing speed, poor memory, hindered socialization, anxiety, and depression. And all of this is linked to just one substance, lead. And we're talking about children who may have been exposed to several substances. For the sake of time, I'm not going to rehash the similar concerns that arise from arsenic poisoning and mercury poisoning and endless other toxins. But to shift gears a little bit, we have to worry about malnutrition in this population as well. The most egregious examples being the ongoing famines in Sudan and Gaza. A history of malnutrition before the age of 5 has been associated with language delay, and there is also a known link with cognitive deficits. It's a similar story to children who have survived infectious disease. The proliferation of infectious disease usually skyrockets during wars, such as measles and cholera, both of which are having a massive resurgence in the eastern Congo right now. Many infectious diseases have indirect effects on the brain and can lead to cognitive deficits downstream.
And I want you to consider that it's not just children who are raised in war zones who suffer all these various toxicities. When we talk about malnutrition, infectious disease, neurotoxic exposure, we also have to consider women who are pregnant in war zones. So even something as simple as lack of prenatal care can put infants at risk of language disorders. Congenital hearing loss, for example, is more common when mothers lack adequate prenatal nutrition that they need. So a more pressing example is the high rates of prematurity and traumatic births in many refugee populations, unfortunately, since both of which are known risk factors for language disorders. Maternal stress during pregnancy has also shown some effect with regards to language development in a negative manner.
Yeah, and what can be more stressful to a pregnant woman than carrying out your pregnancy in a war zone?
Exactly.
Another factor here is head trauma. So unsurprisingly, children suffer a higher rate of TBIs in war zones, and this has all kinds of intuitive effects on language, cognition, hearing, literacy, and even social communication. But to tie all of these biomedical threads together, a key differentiator in this population is lack of early medical care. Many of these issues impact Canadian-born children too, but the difference is Canadian-born children often receive treatment before these issues spiral into full-blown language disorders.
Yeah, these are all great points, Fahim. And I also want to ground us in some psychosocial realities shaped by the factors that you highlighted. So because language development doesn't happen in isolation, it's shaped by the child's emotional world, their history, the environments they've had access to. And globally, refugee children experience elevated rates of PTSD, grief, depression, and anxiety, which are things that you touched up on, relevant to how we interpret behavior and performance in school and clinical settings. So these are things that we really need to take into account. And because trauma is so common, the field should begin, our field as SLPs should begin to move towards trauma-informed care, or TIC. So this can be through small, consistent changes we make in how we speak, assess, set up a safe environment so we minimize harm and maximize access. So I will, of course, link the research if anyone would like to read that over, which I strongly suggest.
It's a little crazy that we're not already on TIC.
Unfortunately, yeah. This is something that we should hopefully see in the future in our field, being educated in schools. But yeah, so there are 5 key things for us to recognize, the first being trauma and emotional dysregulation. So children may struggle with managing their emotions, shifting between tasks, focusing or staying engaged even in the class, and this directly can tie to the executive functioning system, which is responsible for things like attention management, planning, organizing, impulse control, emotional regulation, working memory, and flexible thinking.
Yeah, and from a trauma-informed lens, this matters because the brain is state-dependent.
Yeah, so if a child is in fight, flight, or freeze, the prefrontal cortex just goes offline, meaning their behavior during assessment or session or even in class may actually be a stress response and not a skill deficit. So this is why trauma-informed care encourages us to shift our mindset from what is wrong with this child to what has this child been carrying and what has happened to this child.
Right, because kids in survival mode cannot simultaneously be in learning mode. Recognizing this prevents mislabeling and helps us tailor our sessions to support regulation first.
So when a child can't follow multi-step directions, ask yourself, are we asking an unregulated brain to carry the same load as a regulated brain? Understanding that just changes the context for everything that we see, and it connects perfectly to point 2, sensory processing differences. Because the nervous system is stuck in threat detection mode, it must change how the body is interacting with the world around it. So like a survival mechanism. Because trauma activates the autonomic nervous system, or the ANS, this system is designed to scan the environment for danger, and for a child who has lived through chaos, that scanner is just always on, always activated, and it's on high alert constantly. So this leads to one of 2 things: hypervigilance, which is an extremely heightened sensitivity to things like light or sound or touch, or the opposite, which is hypovigilance.
So this is like kind of when they're dissociated and numb.
Exactly. So a reduced awareness of sensory input. It's a protective numbing mechanism.
I just want to call back to something that we discussed earlier. I kind of discussed a biomedical etiology which leads to a sensory processing disorder, and here we're returning to that theme. Here is a psychosocial etiology which is also converging on that same kind of presentation of a sensory processing disorder. So that just kind of shows how layered and complex a single symptom can be in this population. All right, so just to recap what you were talking about before this, if a child is hypervigilant, every little sound could be a threat. If they're hypovigilant, that means they're like completely checked out, and neither state is good for learning.
Not at all. And this tells us something critical about how we should arrange our physical spaces. So things like quiet corners, using softer lighting, or even just giving a heads up before transitions. These are not luxuries. They're clinical tools that directly help regulate a nervous system that's stuck on high alert.
That's such a great link between the external world and our internal brain state that we talked about earlier.
Okay, let's shift from the sensory processing differences to point 3, survivor's guilt. This one is often invisible, so we risk missing it completely. And this comes from surviving when others didn't, like family, friends, and community members. It's incredibly heavy psychosocial burden to carry. And because it's so complex, it shows up in behaviors that we could easily misread as just shyness or low motivation. So what does that actually look like in a session? You might see this as persistent withdrawal or reduced verbal output.
Like a flat expression.
Yeah, very little or no change in their facial expressions or their tone of voice, no matter what you're talking about, even if it's something that you would assume would be interesting to the child. The child might be really hesitant to discuss any of their experiences, or they might seem sort of unable to engage in anything joyful or playful.
It's like they feel like they don't even deserve to be safe or happy now. It's a very deep type of shame, and it requires an immediate therapeutic response. It's not just something we can note down and move on. But of course, this isn't in our scope of practice.
You're right, it's not. So it's important to know when to refer and to who, which we'll talk about later on, since there are still things that we can do right in the moment. The recommended strategies are all about grounding the child in the present. First, you have to name and validate the emotion. Use languages that normalize it, like, it makes sense that you feel this way after everything that you've been through. You give it a name and you say it's okay. And then you immediately move to sensory motor activities, and this can be anything that connects them back to their body, like tapping their feet on the floor, pressing their hands on their legs, or simply just feeling the chair supporting them.
So in other words, grounding activities.
Exactly. The physical grounding pulls them out of that trauma reaction and allows them to be present. Being aware of strategies for your client can help regulate and ensure effective care. Okay, let's pivot now from the internal experiences to the external context. Point number 4 is gaps in schooling. Interrupted education explains many literacy and narrative differences. Some of these children have never even been inside a classroom before Canada. So when doing an assessment or standardized scores that you may get from these assessments will reflect experience and opportunity that's something that they never had. So not an innate ability that this child shows, for example.
I see.
So this means they lack literacy experiences, exposure to print, knowledge of classroom routines, familiarity with social rules like turn taking.
Yeah, and the quality of a child's schooling matters here too. So you may do an initial assessment on a child, and the intake form might say that the child has received schooling, but in practice, the types of schooling that is provided in these refugee camps are nothing like the type of schooling that Canadian children receive. For example, I'll speak on my father's refugee camp. 16-year-olds would be schooled in the same open-air classrooms as 7-year-olds. And you can only imagine the kind of inadequate curriculum that was provided, which can't possibly fill in the gaps between these massive age groups. What kind of socialization was there? What kind of routine is there in these kinds of open-air classrooms? You really do have to dig deeper if you know that a child is of a refugee background and yet it says that they've been through schooling. What was that schooling like?
I can only imagine how difficult it must have been for your family to learn in those conditions. So thank you for sharing that. But yes, it does connect to this fact that you have to think about what opportunities did these children actually have to build these skills. The absence of the skill often just reflects the absence of opportunity. And that connects to our final point, which is cultural and linguistic alienation. This adds another layer of context that directly affects our ability to build rapport. For so many children, their home language is tied to their identity, their family, their survival. But in a new environment, there's this immense pressure to assimilate, to learn the new language quickly, which often means abandoning their own, and that pressure just compounds that stress. For some communities like the Palestinians, Syrians, Sudanese, and various indigenous families, language isn't just about communication. It carries generations of trauma and resilience. So when a child feels like they have to abandon that, it can feel like a betrayal, a loss of self, and a deep sense of shame.
I just want to zero in on that language alienation piece. In a few of these conflicts, there's an element of linguistic extermination as well. This is not universal in all wars, but the primary examples of linguistic extermination we're seeing are in Western Sudan and in Myanmar currently. And when there's this added layer on top of this, then language takes on this kind of social importance of resilience and preservation of your own identity in a way that it's amplified compared to what we see in other kinds of conflicts. This was the story of my own family. We survived an attempt of linguistic extermination of the Bengali language. And I can say that Bengali is a very important aspect of our diaspora experience over here because of this. So that's just one other thing that you have to keep in mind. You might have this dual experience of shame and at the same time this like outsized importance.
Yeah, because of that shame, you're going to be hesitant to communicate at all. So that's a really great point. Again, thank you for sharing that story. But it really ties back again to that this has nothing to do with their intrinsic ability, but that silence that the child may show in class or in your sessions in clinic might just be a sign of linguistic shame and not a communication disorder.
And it could even manifest as the opposite. Opposite might not be the right word, but it could manifest as like a strong resistance to speaking English or French. Maybe on the part of the child, maybe on the part of the family. Maybe they want their child to have exclusive exposure to their native language at home, and they don't want them to consume media in English or French at home. And this might be coded to us through our lens as somehow resistant or somehow non-compliant. But we have to always be interrogating, could something else be going on here? Could this family have experienced something that we can't understand?
That's a great point. That's true.
Okay, so you've laid out 5 key points to consider. That's the dysregulation, the guilt, the sensory differences, the schooling gaps, and the linguistic alienation. Now, how do we put all of this into practice?
Okay, we can rely on 5 core trauma-informed values. But let's just start with the foundation first of what we can apply in our sessions as well. Safety is the first one. Safety means physical and emotional predictability. If you start with a visual agenda, you never skip it, no matter what. It means having a grounding strategy ready the moment you see even a tiny bit of dysregulation. This brings us to our second value, which is trustworthiness, because in order to create that safe space, you need the child to even trust you. And trust is built through transparency. Visual agendas are definitely a must for these clients, but informed consent for literally every activity is also important.
Right. I mean, these children have just been through a lifetime of instability, so we should integrate stability wherever we can into our therapy.
Yeah, and avoiding surprises is definitely a massive, massive regulatory strategy in itself. That flows right into our third value, which is choice, and something similar to what you just covered right now. In trauma, a person feels out of control. So our goal is to restore it piece by piece, and that can be by offering choices throughout your sessions.
And importantly, not overwhelming them with choices, of course.
No matter what you do, don't try to overwhelm them too much. That's too much. Just give them specific options, like, do you want to work on the story first or the craft first? Let them pick the materials where they sit, or if they want to stand, let them do that. Let them walk around and pick what they want. Co-create goals with them even, and just give them that ownership back. Okay, so this sets us up for value number 4, collaboration. Collaboration just means involving everyone in the client's world, not just a quick call to the social worker. It's actively engaging with family, with the teachers as well. It's stepping outside that clinical bubble and asking families about their cultural priorities.
Right, because we got to make sure that the goals that we set are actually relevant to them.
Exactly. And that leads to the final value, the 5th value, which is empowerment. Empowerment is all about the narrative shift. It means asking a child not just what they struggle with, but what they're good at. It's noticing and saying out loud the small wins, reinforcing competence, using identity-affirming language as well. So it's about shifting their internal script from I am broken to I have agency and I have capacity. But we have to talk about the reality for the provider as well. You as a clinician, delivering this kind of care, it takes a huge toll on you. We have to talk about secondary trauma. So provider wellness should be non-negotiable. You definitely should take self-care strategies into mind, because working with this intimately, and especially regarding trauma, it leads to secondary traumatic stress, or in other words, vicarious trauma, and you start to experience the trauma symptoms yourself.
Right, you do. And if we're dysregulated, we cannot help regulate our clients.
It's that simple. You can't pour from an empty cup, so you have to monitor your own well-being as well.
Yeah, and beyond self-care, there are critical professional boundaries we have to maintain, especially around scope of practice.
Absolutely. You must be crystal clear on your role. Your job is not to treat the trauma narratives, because that's definitely outside your scope.
And trying to can even be dangerous.
Yeah, it can be incredibly risky. You can reactivate their trauma without having any proper clinical framework to help them, which is something we don't want to do.
So when we make those referrals to mental health providers, what should we be looking for?
Well, know the trauma-specific resources in your area first, and know that not all mental health professionals are actually trauma-trained. So look for that, and you can easily just email the therapist to ask about their level of training in trauma, or look at things that they may have trained in, like EMDR or SEP.
We want to communicate collaboratively with these professionals so that the child receives simultaneous supportive care.
Exactly. Okay, so if we pull everything together, the neurobiology, the emotional complexity, the context, this whole operational framework, what's the one central objective we want people to take away from this? The central objective is capacity restoration. Make your space, your clinic, your classroom, the one place where safety, predictability, voice, and choice always live. And when you do that, you stop focusing on forcing compliance and start restoring the neurological accessibility that is required for learning and communication to even happen. That state-dependent learning idea is important, similar to what we talked about before. A child in survival mode cannot access their highest skills. Applying this framework isn't just being kind, you're physically and neurologically enabling their capacity to heal.
Building on this, just as treatment requires care and safety, assessment plays a key role, and it's important to remember that SLPs must also minimize the risk of re-traumatization in all of our assessments and treatments. This means that during our clinical interviews, we're not going to question the parents about exposure to bombs during pregnancy. And we're obviously not going to interview the child directly about their traumas either. They've probably told this story before, either to an official or to a different clinician. So our first stop will be to check in with their doctor, with their social worker, and with their psychologist, if they have one, to get this kind of information about what they've been through and not force them to have to rehash it.
Okay, great point. We don't want to re-traumatize the child, but obviously if the child brings this up, then we make that space a safe space for them to talk about it if they want to. We validate their feelings, but we don't get into too much detail ourselves, because this might cause that trauma narrative that's not in our scope of practice to talk about, and it might definitely be triggering. To continue on assessment considerations, some standard modifications we make for bilingualism, whether or not the child is a refugee, would be how frequent they hear the sound in their own language. For example, in English, the sound g is very frequent compared to the Lebanese Arabic dialect. And I say this because not all Arabic dialects are the same. They can be completely different, okay? So in the Lebanese Arabic dialect, g is way less frequent compared to English.
Okay, so just so I understand you, the risk here is that we're expecting this child to have very good orthographic awareness, very good phonemic awareness of this hard G sound, but really in their native language, they're not getting much, they haven't had much exposure to this sound at all.
No, they haven't.
Okay. All right, I see where you're coming from.
All right. Another thing to consider is how transparent the sound-letter relationship is in the child's language. In some languages, the letter name begins with the sound it represents. If you compare English P and F, for example, what do you think is easier?
I'm guessing P would be easier.
P would be easier in this case because for some multilingual learners, the letter P starts with the P sound, and in their language, they're more familiar with learning letters that have the sound of that letter in the beginning of its name. Versus F, it ends with the F sound, while in Arabic, F starts with the F sound, like Fa, for example.
Fa is the letter name in Arabic in this case.
It is the letter name in this case, and just like P in English, it starts with its sound. And the reason why I'm sharing this with you guys is because when you're doing an assessment, in some cases the child may find difficulty with that orthographic comparison between F and what they see on the paper. And the reason for this is it may not just be because they lack the skill of identifying these sounds in the letter. It could be that it's something they're not familiar with in their language.
The concept that a letter can start with a sound that is not the sound that it makes.
Exactly.
Okay.
And obviously, these aren't things that you have to consider for every single bilingual child. We can't overgeneralize all children. Some children may not find a difficulty between letter names that start with their sound or letter names that don't start with their sound. They may be equally the same. I'm just sharing this in case it helps with your assessments, because if the child does happen to show difficulty, this can be something for you to try and consider. And of course, this obviously depends on the child's dominant language, and you can use support by either doing your own research about the child's first language or communicating with family and just working collaboratively with a team to identify some language differences that can be supportive with regards to your assessment.
So these are just small but meaningful factors that you can take into account that will definitely shape the early literacy tasks that you provide for that child. But differences between some translators as well is something that you can consider, because not all translators are trained to understand the different developmental milestones of the children. For example, if a 2-year-old or a 3-year-old says something incorrect, the translator might just say this child didn't do it right, or they might compensate actually for that child by giving the correct response. But you as an SLP, if you heard this child and you knew their language, you'd be like, oh, this is a 2-year-old, it's normal for them to make this mistake. But you can still note it and document it as a fair error for them to make. Mm-hmm. Versus a translator, they're not going to know that unless they're trained.
Yeah. I mean, like neither of us speak Burmese,
exactly,
so we're not going to be able to know for a child from Myanmar, but we can rely on the parents, we can rely on the siblings, we can rely on an interpreter if we're lucky enough to have one, or our bilingual colleagues.
Yeah. Definitely, obviously, if you can have a CDA or an SLP that knows the language, that'll make your life so much easier, and the life of the child in your session so much easier as well. Another thing for you to consider is that with regards to translations, if you're using a standardized assessment, in the context of Arabic, for example, it will use a standard dialect of Arabic. And because these children, if we take into account their school gaps, they may not be familiar with that standard dialect and only know the dialect of whatever village they grew up in. So it wouldn't be fair to use these standardized assessments if they're not even familiar or fully understand the question you're asking.
So those were some really good notes on bilingualism. We are going to have more resources about bilingual assessment and bilingual treatment in the resources section. Another assessment tip is to ensure that a safe person can be in the room during the assessment if the child needs this. This can be a parent, a sibling. As we mentioned before, a lot of these children have separation anxiety, and being separated in this strange context where they're being assessed, even if it's play-based, they're being assessed, and you are a stranger to them. You don't want to exacerbate the separation anxiety that they already likely have through war. One important caveat here is on comorbidity. So usually when Canadian SLPs are assessing a child, that child is facing maybe one underlying issue, one or maybe two underlying issues. But as we've covered so far, these refugee children are facing multiple overlapping psychosocial and biomedical issues. So the impairment profiles that you have been used to seeing might not match up well with what you're seeing in clinic with a refugee child. One thing to keep in mind throughout the assessment process is that sometimes language just needs to take a backseat. Sometimes you'll discover that this child has so many unmet needs that they have to see psychology or medicine or whoever it may be. They have to see a different professional before they're ready to see you.
So moving on from intervention, it's important that we're advocating for our client outside of our clinic. And what this can look like in the school is making sure your client has the support they need in the classroom. The principles we spoke about earlier, like transparency, they don't just apply between you and the child in your session, but it's also the interprofessional team that you have to be transparent with. For example, if you're seeing that the child isn't making the expected progress, then you should let their teachers and healthcare workers know why this may be happening, why you think this may be happening. And obviously, naturally, this is going to involve some speculation on your part, which may or may not be confirmed by the family, but it's still important to share your insights in order to see if other people in the child's care team have consistent observations. One shift we have to make in our framework is understanding that these children are not inherently disabled as refugees. Rather, it's the barriers surrounding them which are disabling, and we can work as a team to reduce those barriers.
All right. And now we have to talk about a second layer to our advocacy. We must advocate for prevention instead of just cure. And prevention in this case means systemic change. It means we have to be combating the war machine. You'll notice that throughout this podcast, we've been naming the armed conflicts out loud, and this serves two purposes. Firstly, I want our listeners to be familiar with the ongoing conflicts. So when you hear Congo or when you see Myanmar on an intake form, little lights will go off in your head and you'll think back to these intervention guidelines that we've been talking about. But the second reason I named these specific countries is advocacy. We must be literate in the ongoing struggles of war-torn peoples, or else we won't be able to advocate against war.
And just to play devil's advocate, some people might say that advocating against war is too political. So is it really our jobs as SLPs?
Sarah, I'm really glad that you brought that up. The truth is, we are healthcare workers, and we don't exist in a vacuum. Everything we do is political. The policies which determine who gets quality healthcare are political. The policies which determine who becomes disabled in the first place are also political. Our National Association, Speech and Audiology Canada, they've literally published elections toolkits for provincial and national elections. That is political. Several of our provincial regulatory bodies have position statements about decolonization. That is overtly political, and all I'm doing is extending this principle to the global stage. Canada is a nation with global impact, and unfortunately, Canada's government, weapons manufacturers, and investment capital have all been complicit in several of the conflicts we mentioned today. And in our own way, we Canadian SLPs are complicit too.
And how would you say that we're complicit?
One of the ways that SLPs are involved in funding these atrocities is our investment in public sector pensions. In our context as Ontarians, I'm talking about the Ontario Teachers Pension Plan, the Ontario Municipal Employees Retirement System, also known as the OMERS Plan, and the Healthcare of Ontario Pension Plan, or HOOP, all of which cover public sector SLPs. Their portfolios invest in ongoing genocide. And it's my opinion that we are obligated to join the struggle for investment reform. And I've linked some resources in the show notes if you're interested in getting more involved in this struggle. As for our listeners who are opening a private practice, I would strongly urge you to consider a credit union for your business loans rather than one of our big five banks. All of Canada's major banks invest heavily in weapons manufacturing. Alternatives are, again, linked in the show notes. And if you feel like these changes are too big, I encourage SLPs to start with small, meaningful steps. For example, when purchasing therapy materials, take the time to research where they come from and choose sources that align with your values, rather than simply relying on the nearest mainstream retailer. You may be upset to learn that Indigo, the bookstore, is heavily invested in ongoing genocide of the Palestinian people. So, Sarah, we're coming to a close. What would you say are the main takeaways from our podcast?
I believe that we have to get our priorities straight in such complex cases. The central objective is capacity restoration, and what this looks like in practice is empowering children with safety, voice, predictability, and choice.
I agree. I really think that's the core of what we talked about today. Now, just to close off, please take a look at our resources section, and all of the information we referred to is also available in the sources. Thank you so much for listening.
Thank you.